So NRG-BN013 is a phase 3 trial of single-fraction stereotactic radiosurgery versus fractionated radiosurgery for patients who have intact brain metastasis. This study is specifically for patients who have brain metastasis from the 5 most common histologies associated with brain metastasis. Patients are randomized between the 2 radiosurgery regimens, which are 2 commonly used radiosurgery regimens in clinical practice. So some of the common questions are, number 1, in general, who's eligible for this study, or who should we be thinking about for this study? There are patients in practice who receive systemic therapy alone for their brain metastasis, some who really should receive whole brain radiation therapy. This is for the patients who upfront we think are eligible and should receive stereotactic radiosurgery. In this study, we define that as patients who have between 1 to 8 lesions and a minimum tumor size of 1 centimeter and a maximum tumor size of 3 centimeters. Patients can't have left-meningeal disease, typically have a good performance status. Additionally, this is a study in which we are evaluating which radiosurgery regimen is not only going to be more effective, the primary endpoint is local control, but also in the era of modern systemic therapies. So as part of the stratification criteria, we include those agents that are going to be CNS active, either before or after the actual treatment on the protocol. In the future, we'll be able to learn what that interaction is between systemic therapy and radiosurgery. So right now, this study is just open to accrual, and we just had the accruals come to the study as it is. So we don't have any data from the study itself. But I think it's important to note that as sites are evaluating this study and thinking about opening this study at their institution, there are parts in this study and parts of the protocol with regards to the methodology of single fraction and fractionated radiosurgery that are important to be thoughtful of. And programs can use those to come up with new standards for their own clinical practice. For example, the timing between using an MRI scan and actually delivery of radiosurgery treatment, the constraints for both single fraction and fractionated radiosurgery. All of those pieces that are part of this protocol are really part of what modern stereotactic radiosurgery practice is. And so I think those components of the protocol are still useful for sites to use in their clinical practice, even for patients who are not on the particular study. So the next step for our research is hopefully to have a robust accrual. Typically over the NRG portfolio, brain metastasis studies have accrued very well. Our assumption is that we'll be able to accrue 8 patients per month during the course of the study. With any study, for the first couple of months, studies are being activated at a variety of sites, and so the accrual is really little to none. But even in our first real month of accrual, when sites were open and active with the study, we were able to have 7 patients accrued to the study, so I think we're well within that. We'll also have international participation to this particular study, so I think that will boost the accrual as well. Overall, this is a very important question for the field of radiation oncology to really know what is the optimal radiosurgery regimen and will provide us with level 1 evidence as to which is the best radiosurgery approach for patients with intact brain metastasis. I would like physicians to know that this is a very pragmatic design to this trial. This is again open for the majority of patients who have brain metastasis. We typically treat patients who have lung cancer, breast cancer, melanoma, renal cell or GI malignancies. Those are the 5 malignancies that are eligible for this study. Intact brain metastasis are much more common than, for example, postoperative resection cavities. This is what we treat in our routine clinical practice. A lot of the aspects of the clinical trial we've designed to be very pragmatic to allow robust accrual to this study so that we can get an answer to which is the best radiosurgery regimen in the modern era.